to RhAPPcast, the official podcast of rheumatology advanced practice providers, where we explore the evolving science, clinical insights, and real-world challenges shaping rheumatology care today. In this episode, we take a closer look at the complex and often under-recognized relationship between psoriatic arthritis and obesity, how these conditions intersect immunologically, how they influence one another clinically, and what this means for patient management. I'm your host, Amanda Mixon, president of RhAPP, and I'm thrilled to be joined by someone who's played a meaningful role in my own professional journey, Iris Zink, distinguished RhAPP faculty member, educator, and one of the first rheumatology APPs I had the privilege of working with after PA school. She actually also was... I did a rotation with Iris, and I always like to tell the story that in my rotations, I always got A+ in every single rotation other than the one that I did with Iris. So kind of a funny little piece of knowledge there. She brings a wealth of experience and practical wisdom to today's discussion, and together we'll unpack what clinicians need to know to better support this growing and complex patient population. Iris, do you want to introduce yourself?
I'm Iris Zink. I'm a rheumatology nurse practitioner. Obviously, I've been doing this for 26 years. 16 years I worked with another doctor. And then in 2016, my husband and I opened the first nurse practitioner owned and operated rheumatology clinic in the state of Michigan. We serve the underserved. We have 2 clinics now. We are 50% Medicaid population. We take care of Native American population. And that's what my passion is just serving the patients who have not gotten access to care. So that's what we do.
You really are such an inspiration, and you already know that. You're an inspiration to me. So let's go ahead and get started. From an immunologic standpoint, how does obesity function as an inflammatory driver in psoriatic arthritis, and what mechanisms help explain its impact on disease activity?
Well, I think the most concrete evidence of this was when we used to do the vector DA. Remember the vector DA, when we used to do that all the time in patients with rheumatoid arthritis, and you would see the leptin and the resistin be really, really high in the patients who are obese. So we knew even back then that adiposity added to interleukins and TNF and things like that. So I think that's the best answer, is that patients who have more adiposity tissue, that just becomes like their own little endocrine system, kind of pumping out macrophages, interleukins, specifically 6, 17, things like that, and TNF.
So it really is kind of this, having this extra, adipose tissue causes the release of all these inflammatory cytokines, which then further, makes the severity of the psoriatic arthritis worse, and this kind of positive feedback loop, which is why it's so important that we address this, and probably should have been addressing this all along. What does current evidence show about the way in which obesity amplifies psoriatic arthritis severity across key domains, such as peripheral arthritis, enthesitis, skin disease, and axial involvement?
So we know now that people who have a BMI greater than 30, they have worse disease activity. They have more dactylitis, they have more enthesitis, and they have harder disease to control. It's harder to get them down to low disease activity because you have this burning fire of inflammation.
Yeah, even just getting back to that first question about the immunology behind it, which is why it's so important, I think, that we understand the immunology, because then it can actually help us when we're talking to our patients, and also potentially can help, motivate the patient that is a key piece to controlling their disease. All the medicines in the world, potentially may not work as well unless they work on these lifestyle modifications as well. So how does obesity influence the treatment response, and what patterns have you seen in both literature and your own practice?
It's harder to get control of disease activity when patients are morbidly obese. Again, I have patients that are 100 and 150 pounds overweight, and that is hard, but it's a touchy conversation, because the women that come to me have been told that they're crazy, that they have fibromyalgia, they don't have psoriatic arthritis, and you take off their shoes and socks and, oh my gosh, there's psoriasis all over their feet that nobody's ever looked at, or it's in their scalp, or it's in their ears. And so they've been told repeatedly that they'll get better if they just lose weight. So they've been told over and over again that they're fat and that they're crazy, and or that they have fibromyalgia. And so many of my patients come from the pain clinic where they've been getting pain medication or back injections or narcotics, and none of this was even addressed. Luckily, we have a really good podiatry population in Michigan. I lecture at their conferences. They're picking up the psoriatic arthritis a lot faster and then shuffling them back to me, which is helpful. But it's a touchy conversation because these women it's predominantly women, because women who have more obesity have worse disease activity and it's harder to control. But it's touchy.
It really is. It's always such a challenging conversation to have. And honestly, weight assessment is often underemphasized in our world. Why should it be considered an essential component of psoriatic arthritis evaluation, and how do you actually integrate it into your routine?
Well, we do a BMI on all the patients, but you like me because I'm weird. So the first visit, I really start talking about diet in terms of, I give this how to be healthy sheet to all the patients. And I talk about no pop, absolutely no pop ever. And I talk about no, artificial sugars, because that, causes increased pain modifiers in your body. So we start that conversation in the beginning, and I give them a list of anti-inflammatory foods that help with muscle pain and anti-inflammatory foods that help with joint pain. And so we've already kind of laid that foundation. And I tell them, I give this to every single patient. Every single patient gets this how to be healthy sheet. So, it kind of lets them know that we're going to keep talking about this every single visit because it's important.
When you say that I give this to everyone, it also, in some ways, I think, destigmatizes it a little bit, that I'm not just giving this to you because you're obese. I'm giving this to all patients, whether you're obese or you're not, because we know that having a good diet is absolutely key. But I think also kind of laying the groundwork that, yes, this is something, to your point, that needs to be addressed and that you plan on addressing it. I totally agree. I mean, the very first visit, I'm not usually, addressing their weight. I really am trying to gain a level of trust. But then and I have to be honest, earlier in my career, I don't really know that I ever talked to people about their weight unless they brought it up to me, because I was like, I don't know if I was embarrassed or I didn't want to make people feel bad. I certainly didn't want them to think that I was, fat shaming them or, or anything to that point. But again, now really understanding that, increased cardiometabolic and inflammatory comorbid risks in these population they're all there. We have to think about that. I'm interested what your approach kind of is in this comprehensive risk assessment and monitoring.
Well, I think it's a lot easier to have the conversation now because of the GLP-1s. I mean, that has totally opened up the conversation. So, has your primary care talked to you about going on a GLP-1? Have you been tested for diabetes? Do you know what your A1C is? Should we do an A1C today while we're doing your other lab work for your methotrexate or your TB test or whatever? So a lot of times I throw that on there if they haven't had one, because, your pancreas can only take so much, and it's easy to tip yourself over to the diabetic, side. And the patients are frequently asking about it. They're like, how do I get on one of them GLP-1s? I want to get on one of those GLP-1s. Or what do you think? Because I'm all natural girl and acupuncture and all herbal stuff. What do you think about the GLP-1s? And then that kind of flips it around to, well, every single study so far has shown that people who are on these GLP-1s have less inflammation. When they start to lose weight, that their bodies get healthier. So that kind of puts that into like, it's not fat shaming, because now we have a resource. In the old days, it was, well, you're just eating too much and you're not exercising enough. But now we know that there's actually a dysbiosis. There's a problem with the good bacteria, bad bacteria volume in your gut. And so with the fecal transplant studies, which I think are fascinating, that people are getting skinnier because of this decreased inflammation, but also changing their biome, their microbiome.
Absolutely. I could not agree more. I think having these medication options, I don't want to say readily available, because I still think, it can be cost prohibitive, and, there are things that kind of can get in the way of a patient potentially getting them. However, it's definitely made it so much easier to have that discussion with patients, because they are pretty well known at this point. And so you can kind of have that conversation as, hey, through these medicines, like, we really understand that obesity is leading to this inflammatory response and vice versa. So to your point, it's not just you. I mean, and I'll say that to my patients all the time, is like, I get it. You're trying. We're all trying, right? Like we all know how we should eat. We all know how we should exercise, but there's so much more to it, and it's not you. And I think taking some of that off of the patient, that this is not just all your fault, like you've been made to believe your whole life. I think really does help them understand, and then therefore want to actually, make the necessary changes, whether it be medication, diet, whatever it is, to get better. Also knowing that that's going to help control their disease. So how do you actually approach the treatment of obesity? Do you do that in your clinic, or I mean, what are you doing?
So I have a drop-in paragraph that I put at the bottom of the note that gets sent to the primary care that says, the patients on GLP-1 medications have better control of their psoriatic arthritis. There's multiple studies that show that patients with psoriatic arthritis have double the risk of cardiovascular disease. That is a drop-in that I put down there. And in order to decrease that double risk of cardiovascular disease, this patient needs to lose weight. So I have advised them to follow up with you about GLP-1 therapy if appropriate. So I dropped that down there. I also, when I was looking this up beforehand, I saw that early study where if the patients had been obese early on in life, like in a young adulthood, how they are much like twice as likely to convert from psoriasis to psoriatic arthritis, which is so sad. That we could, if we catch that, if we had caught them earlier, maybe we wouldn't be dealing with so much disease activity and damage.
It's like anything else, right? Like the sooner that you find something, the better you can control it. And my hope is again, now that there is so much more education being done, that hopefully we will actually find that as we moved, down the line, that we're not seeing as much psoriatic arthritis because maybe we are catching. I mean, it's all of those things. I really believe that multidisciplinary approach is absolutely key. I'm so fortunate that I have a lot of providers in, my network, in the community, that I can easily say, please go to this person, go to that person. How are you incorporating multidisciplinary partners when managing psoriatic arthritis, just in this context of obesity?
It is very challenging. They used to go to weight management at the local hospital, but that became all about gastric stapling and gastric surgery and things like that. Not everyone's insurance pays for dietitian counseling, which is really, really sad, because that should be like everybody. We should learn how to eat. We should learn how to cook. We should learn how to exercise and incorporate these things. People who have generational poverty, that is just not something that they understand. And the food prices are so crazy high right now that people are relying much more on highly processed foods that are cheaper instead of fruits and vegetables and lean meats, which is less expensive. So, it's just so hard. My patients are waiting 6 months sometimes just to get into a primary care. There's such a huge primary care shortage. Luckily, Michigan State University, where I'm at, just opened a nurse practitioner run clinic for primary care. So we can get patients into nurse practitioners faster, which is awesome. So that is good. A lot of the free clinics are just so overwhelmed that they don't really have the capacity to manage these medications. So it is really difficult. I wish that in rheumatology, we had that capability, but it's just sometimes we have to do prior authorizations for everything. I mean, Plaquenil, it's like, are you kidding me? So I wish that we had the capability in our clinic to write for these medications, but it's not feasible right now.
Well, and again, you deal with such a high risk population, and it's probably easier for me in just a kind of a regular community based hospital system, because I do have access to, I can send a message to GI or to primary care or to whomever I really want the patient to see, and it's really easy. I realize that you don't have that same ability with the patient population that you have, and that's honestly the patient population that probably needs it the most.
Absolutely, yes.
So it's definitely a challenging thing. But I guess the one thing I would say to our listeners is making those connections. Even a few primary care providers that you have on speed dial, or pulmonology or GI or derm. I mean, in this particular group, it's really important because I work really closely with a dermatology PA, and we share multiple patients. And so if basically there's any skin issues, she will see them for me, and vice versa. And so, insurance aside, we will work together, because sometimes, their arthritis is great, but their psoriasis is doing terrible, and, and vice versa. And so it's really important, I think, that we make those connections so that we can help our patients, no matter what the setting.
Absolutely.
Now, looking forward, what emerging research or clinical tools show the most promise in helping clinicians better identify, manage, and mitigate obesity's impact on psoriatic arthritis?
We need more research. I mean, we know that. Well, the studies look really promising right now with the GLP-1s. Now we're identifying that those are causing a decrease in certain interleukins. We know that some of the interleukins cause the problem in the first place, but I think we need a lot more information. My biggest fear is we have seen so many success stories with these GLP-1s, but then there's the what now? When my patient's down to 125 pounds and they're scared to get off the GLP-1, and I totally understand that, there's the what now? Have we researched enough of the microbiome to know if they need a certain probiotic, or have they taught themselves how to eat better, or are they just eating less? So these are my concerns is, what's next? And we don't know what's next. Are they just going to rebound if they go off the medication? Is there a bridge? What are we doing now?
I totally agree. And hopefully, again, as these things are out longer and more readily available, we can actually have the tools to be able to say, okay, here's what you should do. Because you're right. I mean, if however, what weight loss tool you're using, whether it be, medication or what have you, it has to be a lifestyle, because if it's not, then you'll just gain it right back. And, but I think, again, it's just so important that we really understand that weight is inflammatory, like obesity is inflammatory, and just making sure we all have this as a focus when we're talking to our patients is important, because that's one of the only ways, I think, to really get their disease under control. In addition, obviously, to the amazing therapies that we have. When you and I first started, like we didn't have much of anything. And so to have, yes, I mean, truly. And it was like, my gosh, if they couldn't tolerate or, some reason why they couldn't do a TNF, it was like,
Yeah.
well, I have nothing else to offer you. So sorry, and that's where we saw those people in the wheelchairs and stuff like that. And,
Right. We're still using
some of those
gold in your training days.
Yes.
We're still using gold, which is, we had nothing else.
I know. And there's some of those sweet patients that are really, probably you too, really burned in my memory, how disabling and awful these diseases can be. Is there any final thoughts, anything that you might want to share with our listeners?
I thought it was really interesting when I was looking into things that half of the patients with psoriatic arthritis, according to some studies, are obese, which I think we see that a lot in Michigan, but I just think it's because people in Michigan are obese. But I just didn't think nationally that we were seeing that many people with psoriatic arthritis necessarily that are also obese. So do you see that in Colorado? I mean, people are more exercisey and more fit, I think, in Colorado.
Yeah, I would say not as much, certainly, as I saw, when I was in Michigan, but because it's a little bit more health conscious of a state, but by all means, I still definitely see it. And I just think, about that statistic, 50%, imagine what that would look like if those patients, got into a normal BMI, like what that would look like for their disease and their longevity. And, I think it's so fortunate that we are in this such an amazing field where we get to grow old with our patients, and, the ability to be able to see them grow old and them see us grow old together. So I think we really are in a unique position to be able to have those tough conversations that I now have. And again, it's just been so helpful to be able to say to people, this is not your fault. So let's just take the blame out. This is about getting your disease under control, and this is how we're going to do it.
I've seen a couple of patients who went off their biologic, which is like, it's scary, but it's also incredible. When they lose 150 pounds, they go off their biologic and they're like, you know what? Nope. I have completely changed my diet. I am only eating anti-inflammatory foods. I'm exercising 5 days a week, and they go off their drug and you're like, ee! But wow,
It's so incredible. And it just makes me so excited for the future of rheumatology.
Yep, it does. It's very exciting. it was sad in the beginning, like you said. I have photo albums of patients who have died already, and my patients now that I inherited are just, it's like a constant death march because they've had disease for so long and they have so much destruction, and the cardiovascular risk is so high that, the mortality is really, really high. But the young kids coming in, they'll just never know that. I'll never know the patients, the waiting room full of people on oxygen and in wheelchairs. They're just not going to see that anymore.
Absolutely. So incredible. Well, that brings us to the end of this episode of the RhAPPcast. We hope today's discussion shed light on the multifaceted relationship between psoriatic arthritis and obesity and offered practical insights you can bring back to your clinical practice. A sincere thank you to Iris Zink for sharing her expertise and perspective and for continuing to elevate rheumatology education through her work with RhAPP. And thank you to our listeners for joining us and for your ongoing commitment to advancing the care of patients living with rheumatic disease. If you found this episode valuable, we encourage you to subscribe, share it with your colleagues, and explore more educational resources at rhap.org or on our RhAPP ACE 2.0 mobile app. Your engagement helps us continue delivering high-quality, APP-driven content to the rheumatology community. On behalf of RhAPP, I'm Amanda Mixon. We appreciate your time, your dedication, and your partnership in learning. We'll see you next time on RhAPPcast.